Good afternoon, everyone, and thank you for joining this session. My name is Inês Pessanha, and I'm a pediatric general surgeon working at Coimbra Pediatric Hospital of Coimbra in Portugal, and I'm the junior member of our pediatric liver transplantation team. I also collaborate with the adult transplantation team, mainly in organ retrieval and graft preparation. And our surgical team is led by Dr. Catarina Cunha, also with us, who is also a pediatric general surgeon with a special focus on hepatobiliary and digestive surgery, and a senior member of our surgical transplant team. Today's presentation will focus on the challenges in management of persistent ascites after liver transplantation, concluding with a discussion of a particular case that we had the opportunity to manage. We have no potential conflict of interest to report. And to begin, it is important to briefly review the context of ascites in cirrhotic patients. Ascites is the most common clinical manifestation of decompensated cirrhosis, and it affects approximately 5 to 10% of patients with previously compensated liver disease each year. From a pathophysiological perspective, the key driver of ascites formation is the splanchnic arterial vasodilatation, primarily mediated by nitric oxide, and this leads to a reduction in the effective circulating volume and promotes renal sodium and water retention. Portal hypertension and increased hepatic lymph production also plays contributing roles. Liver transplantation remains the best treatment for these patients as it corrects the underlying hemodynamic disturbances and improves renal function, often leading to resolution of ascites. Small to moderate amounts of ascites are relatively common in the early postoperative period, usually resolving with 2 to 4 weeks after transplantation. But when ascites persist beyond that frame time, the 4 weeks, we start talking about persistent ascites. This is a rare complication occurring in about 5 to 7% of liver transplant recipients, but despite its low frequency, it's clinically significant and it is associated with an increased morbidity and mortality. Herzog defined the persistent ascites in children as a 10 milliliters kilogram a day, lasting longer than 10 days. To study the etiology, we can group the causes in 3 boxes: the vascular, the hepatic, and the extrahepatic causes. Starting with the vascular causes, one of the most common causes of persistent post-liver transplant ascites is the hepatic venous outflow obstruction. Among them, we have the inferior vena cava stenosis. It is relatively rare, with an estimated incidence of about 1% and maybe more in children. And this complication is typically iatrogenic, often resulting from surgical technique or graft positioning. And the stenosis is usually located at or just above the caval anastomosis and may not always be evident on the initial imaging studies. It can occur regardless of the surgical technique used, including piggyback or caval anastomosis. The study by Isabel Cirera and colleagues from the Barcelona group has been particularly influential in the shaping of our current understanding of this complication. They describe the post-sinusoidal portal hypertension as the main mechanism of this massive ascites secondary to hepatic outflow difficulties. And they found that the gradient between the free hepatic vein and the right atrial pressures were significantly greater in patients who develop ascites than in patients who did not, as showed in the graphic. However, ascites only appeared when the wedge hepatic venous pressure, which mirrors the sinusoidal pressure, reaches a threshold value of 12. In this study, they also found that hepatic venous outflow obstruction was often due to a caval kinking or graft malpositioning, and not just stenosis or thrombosis. Portal vein thrombosis is also a rare cause of post-transplant ascites, and it's thought to be related to vessel reconstruction, and the incidence is also about 1%, and is more common in patients with prior history of portal vein thrombosis. Other very rare causes related to the vascular apparatus. It is the portal vein stenosis and the arterial portal fistulas. We also have hepatic causes like acute cellular rejection, and may also cause persistent ascites post-liver transplant. And the proposed mechanism for that is the increased liver vascular compliance during rejection episode. The ascites typically resolve after successful treatments of the cellular rejection. Cirrhosis induced by hepatitis C as well as recurrent hepatitis C also contributes to an ascites after liver transplant, but it's a very, very rare cause in children. The workup of patients with persistent ascites after liver transplant also should be directed to exclude extrahepatic causes as heart failure, chronic renal disease, malignancy, infection. And based on some published case reports, these ascites also can be tacrolimus induced. And finally, the etiology can remain unknown. And one hypothesis is that this type of ascites results from persisting collateral circulation and large splanchnic blood volume, resulting from a disproportion between portal venous blood volume and the liver uptake. The major negative impact of persistent ascites after liver transplant is the reduced patient survival, as already mentioned. However, the additional risk of that seems to disappear if the refractory ascites also disappears. In the same study, the patients with unknown reason for refractory ascites after liver transplant had a significantly higher rate of disappearance. And furthermore, persistent ascites after liver transplant is also associated with renal impairment, increased incidence of peritonitis, and prolonged hospitalization. These patients' evaluations should start with a laboratory evaluation, assesses liver and renal function. There should be a low threshold to evaluate for viral infections. In cases where cardiac etiology is clinically possible, NT-proBNP levels should be measured. And we also should do a diagnostic paracentesis for cytological and microbiological examinations. The next step in the evaluation should be an ultrasound of the abdomen with a doppler to assess for vascular obstructions. In case of hepatic venous outflow obstruction, we can find an increase in flow velocity across suspected stenosis or a waveform dampening of the hepatic vein. An echo could be done when a cardiac cause is suspected, and venography and invasive hemodynamic evaluation should be performed as a confirmation method for the suspected mechanical obstruction. In most cases, the HBO, an invasive measure gradient greater than 3 is considered significant. A biopsy should be performed in cases where the diagnosis is unclear or when there is a high probability of rejection. For the treatment, some patients have clinical resolution of ascites within 6 months, with most of them requiring only diuretics and paracentesis. But the primary goal for treating for this treatment is to address the underlying cause when it is identifiable and modifiable. However, during the diagnostic evaluation or when the cause of persistent ascites is unknown, the treatment approach to these ascites should follow the same principles as those in pre-transplant period: fluid and sodium balance, infection control, and supportive care. This table provides an overview of treatment strategies according to etiology. It was taken from a published source that mainly focuses on adult transplantation, but the principles are still broadly applicable. Vascular complications causing stenosis are considered completely curable when diagnosed and treated promptly. The most common of those, stenosis of the hepatic vein, is easily treated with plain balloon angioplasty. Successful procedure results in an immediate resolution of the pressure gradient, followed by an early clinical resolution of the ascites. A stent should be placed in cases who are irresponsive to the balloon angioplasty, or in those who develop a restenosis due to recoil. The same approach is used in the case of portal vein stenosis with similar success rate. A somewhat higher risk of primarily bleeding complication relates to the transhepatic approach. However, it can be successfully treated with embolization. Stenosis of the inferior vena cava is usually iatrogenic or connected to scar formation, and for this reason, larger balloons with multiple inflations are needed to achieve adequate results, and for the same reason, stent placement is more common than in other types of stenosis. In the hepatic causes, including recurrent hepatitis C and acute cellular rejections, they should be treated following the latest guidelines. In cases of peritonitis, empirical intravenous antibiotics should be started immediately, as the prognosis of patients with bacterial peritonitis as cause of the ascites is associated with a very poor outcomes. TIPS and splenic artery embolization are treatment methods in patients with refractory ascites of unknown cause. Starting our case presentation. So this case is about a 6-year-old boy diagnosed with alpha-1 antitrypsin deficiency who developed cirrhosis and portal hypertension, complicated by ascites and gastrointestinal hemorrhage. He underwent liver transplantation after a prolonged admission due to the compensation with infections, adenovirus, rotavirus, varicella zoster virus, and the patient also fulfilled the diagnostic criteria for hepatorenal syndrome, acute kidney injury, and need of ICU stay. He was transplanted with a reduced size graft from deceased donor. At the time of the hepatectomy, moderate ascites, 800 milliliters, was observed, consistent with his previous portal hypertension. The graft was implanted using the piggyback technique. It was not possible to triangulate the hepatocaval anastomosis due to the anatomy of the donor hepatic veins. And for portal reconstruction, we used the left portal vein from donor that was sutured to the recipient main portal vein. The donor left hepatic artery from a left gastric was anastomosed with the recipient's common hepatic artery. A Roux-en-Y reconstruction was used for biliary drainage. No intraoperative complications were recorded. Intraoperative Doppler evaluation demonstrated adequate flow patency across the hepatic artery and portal vein and physiological modulation at hepatocaval anastomosis. So intraoperative and early postoperative Doppler studies showed satisfactory vascular flows. He was successfully extubated on day 1 post-surgery. Oral feeds were started on day 4. But on postoperative day 5, following a single dose of aspirin, hemoglobin dropped from 7.3 to 4.7 with no evidence of bleeding initially. However, the patient developed melena a few hours later. They persisted from day 5 to day 9 and required multiple transfusions. An endoscopy was performed, but no active bleeding cause was identified. Given the surgical reconstruction, the Roux-en-Y limb was considered the most likely source, although it was not directly visualized. The melena resolved spontaneously without further intervention. The graft exhibits a favorable function response as reflected by the progressive normalization of cytolysis and cholestasis markers, and Doppler ultrasound revealed no abnormalities. Then a persistent high drainage output was noticed. This graph shows the daily mean abdominal drainage volume in the postoperative period expressed in the postoperative days. During the first postoperative month, the patient had an average daily abdominal drainage output exceeding 1,000 milliliters a day. Several cytological and microbiological analyses ruled out spontaneous bacterial peritonitis. In the etiology workup, we excluded extrahepatic causes. NICO demonstrated normal cardiac anatomy and preserved function. The patient remains on optimized diuretic therapy under furosemide and spironolactone with serum albumin replacement. Ascitic fluid cultures remain consistently negative. Despite the marked ascites, the liver grafts demonstrated favorable evolution with no signs of dysfunction, and the patient was maintained on a triple immunosuppressive therapy consisting of mycophenolate, corticoids, and low-dose tacrolimus. Considering the pre-transplant predictors for our patients had the presence of ascites in the pre-transplant period and an hepatorenal syndrome as factors who significantly influence the development of this post-transplant ascites. A vascular cause was suspected based on imaging. Doppler showed patent hepatic veins, mild cardiac modulation, a segmental narrowing, and a marked waveform acceleration. The CT scan also suggests a narrowing at the hepatocaval confluence, possibly causing the obstruction. This is the same graph previously presented. We can see persistently massive drainage volumes consistent with the refractory ascites. On the postoperative day 32, the patient underwent a venography that confirmed the suspected hepatic venous outflow obstruction. Mild stenosis at the junction of the inferior vena cava with the middle and left hepatic veins. And then the first angioplasty was performed with normalization of the gradient. A biopsy was performed at this procedure, and histopathological evaluation revealed no signs of acute cellular rejection. And following this intervention, there was a noticeable decline in drainage, although not complete. At day 40, a Doppler ultrasound revealed a patent cava with dynamic collapse of its infradiaphragmatic portion in supine and left lateral decubitus associated with elevated flow velocities. This finds normalized in the upright position with velocities decreasing to 50, suggesting a positional outflow impairment. Also, the hepatic veins remained patent with a hepatofugal flow. However, diminished cardiac modulation was observed in the supine position, which improved upon standing, further supporting the dynamic outflow resistance. So, at that moment, we had a Doppler suggesting positional outflow impairment, possibly a kinking. And on the other hand, we have a previous angioplasty with normalization of pressure gradient, suggesting a stenosis. As the graph continued very well in terms of the function, we decided to repeat the angioplasty. So on the day 62, the second angioplasty was performed due to persistent clinical signs suggestive of residual outflow difficulties, accompanied by a renewed increase in the abdominal drainage output. After the second procedure, drainage volumes dropped significantly and the ascites progressively resolved. Finally, the abdominal drain was removed on the postoperative day 69 after sustained clinical improvement and minimal output. The patient's ascites resolved gradually after the second vascular intervention. The drain was off in 7 days. There was a Doppler normalization, despite some flow acceleration at the hepatocaval confluence segment, and the patient was discharged on the day 64, stable clinical course thereafter. At 3.5 months post-liver transplant, a repeat hepatic venography was performed along with a liver biopsy during the same procedure. One more time, histopathological evaluation revealed no signs of acute rejection or fibrosis. Angioplasty was not carried out at this time, as cavography and selective hepatic vein venography showed no evidence of stenosis, and no significant pressure gradient was observed between the hepatic veins and the inferior vena cava. Thus, no intervention was deemed necessary. At that time, there were no signs of ascites, and the abdomen was soft and non-distended. At 1 year post-liver transplant, the patient remains in good clinical condition with appropriate weight gain and no recurrence of ascites. Laboratory parameters are within normal limits with no elevation in hepatic enzymes. Renal function has normalized. Current immunosuppressive therapy includes tacrolimus and mycophenolate, and the ultrasound with Doppler shows a patent hepatic veins with normal hepatofugal flow and preserved cardiac modulation. At the confluence of the inferior vena cava, there is a mild increase in flow velocity corresponding to an estimated stenosis for less than 50%, considered not hemodynamically or clinical significant, and the inferior vena cava is patent. One more time, the liver biopsy revealed no histological signs of rejection or fibrosis, and the only important medical complication by now is a marked adenoidal hypertrophy, currently under evaluation for surgical management.